Welcome to the Multiple Sclerosis Summit Series Part 2, presented by the Northwestern University Feinberg School of Medicine at NeuroSeries Live. My name is Dr. Bruce Cohen from the Davey Department of Neurology and Clinical Neurosciences and the Comprehensive Multiple Sclerosis Center at the Northwestern University Feinberg School of Medicine. I'm pleased to serve as the chair for the Multiple Sclerosis Virtual Education Summit Series. Today, we'll be talking about differential diagnosis and the potential role of biomarkers in diagnosing and managing multiple sclerosis. If you missed Part 1 of our Multiple Sclerosis Summit series, please log on to neuroserieslive.com to view on-demand presentations. Our first presentation today is the Differential Diagnosis of Multiple Sclerosis Tips from Experts, presented by Dr. Aaron Miller from the Corinne Goldsmith Dickinson MS Center at the Icahn School of Medicine, Mount Sinai, New York. The second presentation will be by Dr. Suhail Dahib-Jabboud from the Robert Woods Johnson School of Medicine in New Brunswick, New Jersey, who will speak on the potential role of biomarkers in diagnosing and managing MS. Each of our speakers will be able to take your questions in real time throughout their presentation. You can send your questions during the program through the box in the lower left-hand side of your screen. Once again, thank you for joining us.
Thank you, Dr. Cohen. My name is Dr. Michelle Fabian, and I'm Assistant Professor of Neurology at Icahn School of Medicine in Mount Sinai. I'd now like to introduce Dr. Aaron Miller. Welcome, Dr. Miller.
Good morning.
Good morning.
So my job today is to talk a little bit about the diagnosis of multiple sclerosis. And rather than give you a laundry list of entities that can be confused with MS, I want to talk really about the principles of making a diagnosis, some of the entities that are confused with multiple sclerosis because they're of a similar inflammatory nature, and then talk a little bit about what are the things that personally confuse me and make my life difficult as an MS subspecialist. Well, for at least 150, close to 200 years now, we've had basic principles upon which we base the diagnosis of MS. And as you know, we're always looking for evidence of a disease process that affects the central nervous system, the brain, the spinal cord, and the optic nerves, with lesions that are disseminated in time and space. For many, many years, of course, we required this evidence to be on a clinical basis, but now we have imaging criteria that greatly facilitate the diagnosis of MS. But no matter what scheme one uses, going back to the 1960s, the Schumacher criteria that we'll discuss in a moment, there always is the caveat that there be no better explanation for the clinical and imaging findings. Perhaps the first codified system for making a diagnosis of MS that were published were the Schumacher criteria in 1965. And George Schumacher was a neurologist in Vermont, and he required that a patient be between the ages of 10 and 50, that there be objective changes on the neurological examination, that there be 2 or more separate lesions in the central nervous system which predominantly affected the white matter. A person had to have at least 2 episodes that were separated by a month, and they had to last more than 24 hours. Or alternatively, for the progressive forms of MS, there had to be evidence of progression over 6 months in time. And again, that inevitable requirement that there be no better explanation for the disorder. Now, of course, in the mid-1960s, there was no useful neuroimaging, so this was all on clinical grounds. The Schumacher criteria were replaced in the early 1980s by a set of criteria designed by another neurologist then in Vermont, Charles Poser. And I'm not going to delineate all of these. These were a very complicated formula that subdivided MS into clinically definite, laboratory-supported MS, probable MS, and possible MS. The criteria were originally designed for research purposes, but were adopted into widespread clinical use. These were in use for nearly 20 years, but when the Poser criteria were developed, MRI was just bursting onto the scene. And over the next 2 decades, we learned a tremendous amount about MS from magnetic resonance imaging, and it seemed time to start to incorporate MR into the modern diagnosis of MS. So an international panel was convened initially in London in 2000, chaired by the late Ian MacDonald, and the criteria subsequently were named in his memory and are referred to as the MacDonald criteria. I'm not going to talk about the first iteration of these criteria in 2000, but I am going to mention the revision in 2005 that came out of a meeting of the panel in Amsterdam. But both the 2000 version of the MacDonald criteria and the 2005 version required, for the demonstration of dissemination in space, the use of criteria that were developed by a Dutch neuroradiologist named Fred Barkhoff. So these are referred to as the Barkhoff criteria. And you were required to meet at least 3 out of 4 bullet points. So the first bullet point required, it actually had 2 alternate possibilities. Either you had any gadolinium enhanced lesion, or you had at least 9 T2 hyperintense lesions. The second bullet point was any infratentorial lesion, usually a lesion in the brainstem or cerebellum. And the third was a juxtacortical lesion. These are usually small lesions at the gray-white junction. And fourth was the presence of 3 or more lesions in the characteristic periventricular zone. A spinal cord lesion could substitute for a brain lesion. The dissemination in time criteria at that point were still a little bit unwieldy. I'm not going to belabor those, but I'm going to go to the newer time criteria on the 2010 revision after a meeting of the panel in Dublin. This Dublin meeting greatly simplified the requirements for either dissemination in space or dissemination in time. So that now for dissemination in space, one required only having a single lesion in at least 2 characteristic locations: a periventricular lesion, a juxtacortical lesion, an infratentorial lesion, or a spinal cord lesion. There was, however, the admonition that you couldn't count the lesion if it was the one responsible for the clinical symptomatology. So to make a diagnosis of MS, you required a patient with a clinical episode, and the MRI needed to show these requirements for dissemination in space. Now, for dissemination in time, things became very, very much simpler than they had been previously. Now one requires only the development of any new lesion at any time after any previous MRI scan. So I refer to these criteria as any 2, any new. It makes it simpler to remember. Now, of course, although we can accept 2 lesions in these characteristic spaces, I personally am still much more comfortable when I see an MRI that meets the old Barkhoff criteria. And fortunately, most of the patients that come to